this is Rodney Peyton, and I'm the person who designed and developed what is known globally as the Peyton 4-step method for teaching complex surgical procedures. Now that was designed in the 1980s, late 80s, early 90s, especially for my own training, but then with training with the Royal College of Surgeons. And since then, it's been investigated in many universities around the world. I happen to look online just at the moment and I find things from University of Maryland in the United States, from the University of Western Australia, from University of Ljubljana in Slovenia, and also from a nursing perspective and nurse education. So it has been looked at around the world and it is used for all processes for teaching complex skills. Now, why did it evolve? And people have asked me then when I was recently in Germany, said, has it evolved? What has changed since you first put this out in your book in 1998? So let's go back to basics. What was the purpose of it in the first place? The purpose of it was so that trainees could feel secure. They could be confident and competent once they had undergone this training so that they could carry out these procedures themselves. It also gave confidence to trainers who knew how to run people through the process and knew when it was the time to let others take over and perform the surgical procedures. And finally, and most importantly, right at the top of the pile, it was most important for patients. There was no more see one, do one, teach one, but patients would not be operated on by an L driver. That they were entitled to a standard of care and no one was allowed to operate on them unless they could demonstrate that level of competence. So it was 4 stages. The first is observation. The second, deconstruction. The third, reconstruction. And the 4th stage then, the operational stage. So let's just look at those 4 stages and see how they've changed and why they are the way they are. The first is observation. I've actually seen in a number of patients, people say, why do we have to do that? Why should we have to observe in the first place? Well, there's actually an extremely good reason. The brain takes in an overview, an overpicture of what it's going to do. And it needs that. It's rather like doing a jigsaw. If you can imagine doing a jigsaw without the box, especially a 5,000 piece jigsaw, no picture, it takes a lot longer to do, and that's what we find. I look at some of these papers and I look at with interest. They're looking at very basic skills. And they say, you see, we didn't need to allow people to observe before we did them. For instance, in resuscitation, intubation or chest compression. The point they miss is, in fact, people have been observing them. These young doctors they're teaching have seen resuscitation, they have seen intubation, so they know very well what to do. They have already had that observational mode completed. No one said that you have to follow and start from the very beginning to observe again if you already have seen the process which you're being taught. The second part of this is then deconstruction. This is very important for the teacher and the student. For the teacher is used to habit. They've learnt a lot of tricks and they can't accurately describe how to do the particular procedure. And if they can't actually describe it, how can someone else learn? And I find that very interesting when I've been teaching around the world, for instance, on training the trainers courses, and something as simple as tying a knot. When you ask an experienced consultant to teach a junior who hasn't done it before how to tie a knot, they're all fingers and thumbs. They say, well, you do this or you do that. And they can't accurately describe what they do. As they learn to teach and they learn to break down their skills and understand how to say precisely what the skill is, then the teacher actually becomes a better teacher. 1, they can say what they do, but 2, they can also think, well, why do I do it that way? Especially in a complex operation. Is there not another way? And that's where you get surgical innovation coming on, when teachers actually start to think about what they do instead of doing it by habit. When this came to me, was actually very early on when I was doing GI surgery, and my boss started to teach me how to do a Whipple's procedure to operate in the pancreas. And we stood there for about 2 and a bit hours, and he taught me all the way through it. And then you do this, and then I do this, and sometimes I do that, and sometimes I do the other thing. By the end of the 2.5 hours, my mind was frazzled. He was happily just describing things. My mind could not take that amount of information in. And then when the next one came along, he said, well, you've seen one of these. Would you like to try it? And I'll stand with you and do it. And what I found is you just could not do it. You didn't know the detail. You couldn't possibly learn all of that information in one go. And that's where the concept of pivotal or nodal points comes in. All of us doing complex surgery, we know 10 or 12 particularly complex operations that we carry out. And there are certain key steps within that process which are vital in a chain to get that operation completed. The concept with nodal points was to understand that a trainee cannot take it all in at once, and you concentrate on specific points that that trainee needs to learn. You teach them those points and then do that over a number of operations, and then, like someone playing sheet music, instead of going back to the beginning and running through the whole thing, you practice those bars you need to practice before you go back and you complete the whole procedure. So I learned that early on, and that is why stage 2 is so vital. That stage 2 looks at those nodal points, those pivotal points. So you deconstruct to find out the basics of how you do this. Then in the trainee's mind, you have to reconstruct. The trainee needs to become consciously competent of what they do. And the only way you know that they're getting there is when they can explain to you in words of one syllable exactly what to do next. You're still carrying out the operation as a trainer, but the trainee describes that operation as you go along, and you listen to make sure they get it right. And it's only when they can get it right and explain exactly what they're going to do that they're ready for stage 4, which ready for the time where they can carry out the procedure under supervision. And in that they go from conscious competence to unconscious competence, where they learn the neural pathways. It's simple NLP, neuro-linguistic programming, where you learn the neural pathways to control these hands so that you can carry out the operation competently and effectively. So that was the basic overview to begin with. And some of the myths that have sprung up, like for stage 1 you must stand at the operating table. You don't. You can use video, you can use slides. People can look at it on the internet, providing it is the same operation and being done the same way. So with a bit of thought, there's no need to be in the operating room 4 times to do this. Stage 2 is simply talking through it, where the trainer talks through it, and again, that can be done online, on video. So the biggest of all that has to be done is stage 3. And there have been a number of investigations, most notably from Cologne and Heidelberg, where they have actually identified that stage 3 is the key process in all of this. Stage 3, where the trainee actually has to speak through the operation before they put their hands on a patient, while the trainer is still in charge and doing the operation. This stage is vital, and it's where the concept of mental training or cognitive training comes in. This comes from sport, and one of the additions that we've done over the years is to bring in cognitive or mental training along with that stage 3. Now, cognitive training has 2 parts. It has active speech and passive speech. So active visualization is saying I am doing this, and I am doing that, and I am doing the other thing. You almost close your eyes and imagine yourself undertaking that procedure, a bit like a Formula 1 driver going around the track. What has been more commonly used, of course, is the passive visualization. We said, well, if I was to do this operation, I would do this and I would do that. That is not the same at all. You're not feeling it, you're not imagining what you're doing and going through the process. So for instance, a complex procedure, you would ask the trainee, well, tell me what you would do. And they say, well, I would do this and I would do that. That's the passive visualization. They say, now what I want you to do is I want you to go and sit on your own. Think what you're going to do. I want you to close your eyes and go through the operation in your head. Imagine yourself, I am, use those words, I am doing it, I am doing this, and I am doing that. And even as I speak, you can see that as you think that way, your hands automatically move. This is preparing your brain from your knowledge to take it through into practice. So that active visualization, for which I'm very grateful for a lot of the teachers that I've been with, my very good friends Mark Immenroth and Jürgen Brenner from the European Surgical Institute in Hamburg, where they produced papers, you'll find it in the Annals of Surgery, I think around 2008, where they showed very clearly how the difference between passive and active visualization helps people to undertake complex procedures. So that is how it's evolved. It's still a 4-stage process, and those 4 stages are necessary. Add to that, in stage 3 and between stage 3 and stage 4, the process of passive and active visualization. And that is where you become more efficient, effective at undertaking new surgical techniques. So that's how it's evolved. It's one of the most powerful techniques there is for teaching surgery at any level. I teach this around the world, and I taught laparoscopic surgery when it first came out in the UK, all the way through the Middle East, in places like Lebanon, as well as Egypt. So we taught these methods, and we helped people learn quickly and effectively, because I couldn't stay there for a long period of time. We're there for maybe 3 to 4 days, undertaking 12, 14 operations. So we had to be able to teach this quickly, efficiently, and effectively. So it saves trainee time, it saves operating time, it saves the theatre time altogether, and it's also extremely cost effective. So whether you're an individual, whether you're on behalf of a department or working for an institution, you can see how this is so important for you as a concept to get hold of in your surgical training. So, as I said, my name is Rodney Peyton. I am the person who developed and designed this, and if you wish to get in touch with me to discuss these concepts any further, just look at the numbers that come up below. I look forward to hearing from you.